My name is Ellie Wishart. I am the Medical Affairs Manager for Nanosonics for the UK and Ireland. I welcome you to our workshop symposium that we have this morning. I am a microbiologist by background and have worked in infection prevention for over 20 years. So working for Nanosonics as Medical Affairs Manager, I am here today to talk about ultrasound probe reprocessing. So we recognise that medical devices are associated with a risk of HAIs, but how closely do we look at ultrasound probes? So today I'm going to talk you through an overview of the clinical evidence on the role of these probes in transmission risk, and also highlight and describe some of the proper infection prevention interventions that you need to put in place. So we know these devices are widely used across healthcare settings, but it's understanding how we think of them in terms of their risks to patients. So we're also going to have a look at how you can deliver high-level disinfection at the point of care, and that's something that you can deliver closely with full process reproducibility, traceability, but also, most importantly, material compatibility for the probes that you process. So something that you're all very familiar with working in the field of infection prevention, why are we here today? Why are we talking about infections that are acquired during the care of patients whilst they're in healthcare? But we know they're the most frequent medical adverse event worldwide, and they have big physical and emotional impact on patients and high financial costs for medical and healthcare organisations. So, for example, an outbreak that was identified in Belgium, where they linked it to a TOE probe, impacted 42 patients and cost that healthcare facility over €250,000. But what's most striking is that some of these infections, in fact a large proportion of these infections, as we all know, are preventable. And that's why we're here today talking about how we prevent these infections. So here are some key numbers you're probably very familiar with. Almost 9 million patients and HAIs are recorded annually in Europe, with 7 to 15% of those patients acquire at least one healthcare-acquired infections while they're in hospital. But again, looking at how many of these are preventable, up to 55% of them are preventable. So how are we doing that today, and how are we doing that in relation to ultrasound probes? So we know in healthcare the surfaces and the environment around the patients can be a pathogen reservoir. But what's surprising sometimes is to understand how long some of these pathogens remain in the environment. And so looking at these pathogens that persist in surfaces for several months, and studies have shown that the healthcare environment, as well as the ultrasound environment, is a pathogen reservoir. And so looking at how we look at these medical devices and the surfaces around the patient are then disinfected to ensure that you are killing pathogens and, most importantly, preventing cross-transmission from patient to patient. So essentially looking at how these surfaces are then disinfected to help prevent healthcare-associated infections. So specifically coming to look at HPV, so with this particular topic, we know with HPV it's the number one cause of cervical cancer in healthy women. And so associated with the use of ultrasound probe, we know the risk with HPV is that when you start to look at the contamination levels, in this particular study, they looked to see what the kind of contamination levels would be, and 3 to 7% of the probes were still contaminated with HPV DNA after reprocessing with low-level disinfection and a manual wipe system. And so they were indicating that there was still a risk remaining on these probes, even though they had been disinfected. And so looking as well at some of the environment in another study, finding that HPV DNA was found in the environment, including, say, the colposcopes, the lamps, the glove boxes, the ultrasound gel tubes, so essentially all of the equipment that you have in that environment around the patient. So not only the probes themselves, but the environment around the patient. And with HPV and use of endocavitary ultrasound probes, you can also see that this slide also shows that it's not only a concern in women's health, it's a concern in other areas of medicine as well. And where these probes have contact within the patient, they're also where HPV can exhibit its most carcinogenic effects. So really looking at how these probes are used in high-risk patients as well. So if a contaminated probe can contact any mucous membranes, for example, it creates a higher risk for that HPV transmission. So that transmission for a probe where, like we saw on the previous slide, could still be contaminated after a manual wipe system, you can then transmit from probe to patient. And probably something familiar to you all in terms of looking at routes of pathogen transmission, but really focusing on the probes at the centre of the slide have connection to the environment, they have connection to patients and connections to the healthcare worker. So that transfer of contamination through all those different surfaces and between those different people in the environment, you can easily see how the chain of transmission works. But the idea then, with the use of these medical devices and ultrasound probes, is that you can break the chain of transmission through proper disinfection. And actually then looking to see at ultrasound probe use, there's a variety of different probes that are used. There's a huge variety of different probes when you look at it, but also the types of procedures that they're used. So sometimes we forget about surface probes and how they're used. Are they low risk? Because a surface probe just touches the skin, but actually when you're using them in semi-invasive procedures, so things like drainages, biopsy, needle guidance, that's a semi-invasive procedure. So your risk is considered to be higher. So really, you're looking at things like needle guidance, you do have to consider the risk associated with those probes. So with surface probes and endocavitary probes, you really have to consider the level of disinfection that you need and making sure that's as thorough as possible. But when you look at the procedure of how you're going to set up for the next patient, you need to consider all of the different areas that could impact on the patient and what you're using. So for example, you have to consider the infection prevention element of both the ultrasound probe itself. So how is that being cleaned and disinfected? Have you considered the risk according to Spalding classification, which essentially is, underpinning all the worldwide guidance around ultrasound probes and risk? But also looking at your transmission gel. So where the gel is being used, is it sterile? Is it non-sterile? Is it single-use or multi-use? And then the use of probe covers. So putting all those pieces together, are you considering the infection prevention elements or considering the best and most appropriate choice for your patients? So essentially, you should have an SOP that covers all of these elements. So looking at where ultrasound probes are exposed, they're exposed to a huge variety of biological hazards, and I'm sure you've seen probes with these kind of hazards sometimes, visibly contaminated with blood. But sometimes we can identify that actually ultrasound probes need to be decontaminated to help protect patients, but also the staff. We have a responsibility to staff who work in our healthcare environments under cost regulations to ensure that they are safe, what they're using is safe, and are protecting them as well. So this is why we need decontamination before every use to help patients and staff. So looking now at some of the evidence of where we see contamination of probes and where it's been identified through various different studies, there was one systematic review that looked at TV and TR probes and specifically looking at where they had a wipe or spray disinfection. So with these probes, they could see a 12% prevalence of pathogenic bacteria and a 1% prevalence of frequently occurring viruses. So where we see that kind of contamination still remaining, we recognize that sometimes these kind of systems of disinfection using a wipe or a spray is still leaving some kind of contamination left on the probe. This is a study that was carried out in Münster University in Germany. And so they were really keen to understand how they assessed the contamination on their probes, but they were recognizing as well their SOP actually didn't cover disinfection of the handle. So surprisingly, when they went to look, they found that the actual probe body had a 21% rate where they could see contamination, but the handle had a very, very high rate of contamination because they weren't focusing on the handle at all. So they were recognizing that the SOP clearly didn't understand the process and they weren't looking at the whole probe itself. So as many of you would recognize, if you're using a device and where it's been handled and how it's been used, of course you have to consider the whole device and not just the bit that we think that has the patient contact. In this particular article, it was in Australia, where they looked at different facilities and actually looking at different areas. We might consider use of ultrasound probes traditionally in radiology, in ultrasound departments, but actually, as I mentioned before, extensively used across the hospital, so in the emergency department and in ICU. So here you have invasive procedures being carried out, but you also have vulnerable immunocompromised patients. So how do you consider the risk when you use probes for those patients? So they're definitely at higher risk of infection if the probes are not being properly disinfected. So every second probe that they looked at were contaminated with bacteria or blood. And even where they saw that blood contamination, only half of it was actually visible. So what we don't understand is this invisible, unknown risk with the use of probes. And I think that's where the challenge is, where people don't understand where the risk applies to them or their patients, is because they can't see it. And they can't see where the contamination is. So you can see in terms of recognizing the environment, as I mentioned, so it's not just the probe. They also looked at the gel, the keyboard, the transducer, and some of the work surfaces around the patient as well. So recognizing, we can focus on the probe, but we also have to focus on the environment as well. Some of you may be familiar with some guidance that was developed and mandated in Scotland in 2018, but what preceded all of that is a huge epidemiological study that was done. And they recognized that looking at almost 1 million patients, so they looked at their records over a period of 6 years, and the retrospective study was to look at whether or not these patients had infections after they had an ultrasound procedure. So did they develop infections, and were they prescribed antibiotics? And so they found through looking at this that they had identified an unacceptable risk, and the unacceptable risk of patient infection following endocavitary procedures. So you don't imagine that your patient who's going to come in and have a procedure involving an endocavitary probe, in that 30 days after where they go home, are going to be infected. So they looked at 2 different cohorts of patients. In the gynecology cohort, they had a 41% greater risk of infection for the patients that had a transvaginal ultrasound procedure to those who had not. So it's a very, very clear definition that those patients have been exposed to risk whilst they've been in a healthcare environment. And a 26% greater risk if they had an antibiotic prescription as well. So you can see the clear comparison to patients who had had no ultrasound procedure to those who had. But what they were recognizing in these facilities when they were asking questions about what they did with their probes, they found they were using low-level disinfectant wipes or sprays to disinfect the probes. In the urology cohort, the numbers are even higher. So you have a 3.4 times greater risk of infection and a 75% greater risk of antibiotic prescription. So recognizing again this unacceptable risk that they identified through this study, this more or less led to its development of all of the guidance in Scotland to require high-level disinfection for ultrasound probes, and specifically looking at endocavitary probes as well. So it's where the evidence, as we know, informs guidance, and the evidence is building all the time. So coming back to look at surface ultrasound, and I mentioned earlier about considering surface ultrasound as maybe low risk, but actually it doesn't always mean that. The level of risk should always be determined by the procedure. So it's not the type of probe that you're using, it's the procedure itself. And so in this large multi-center trial, they recognized ultrasound was associated with increased infection risk. So they're looking at CVC placements at the jugular and femoral sites. So they can clearly identify where they had an increase in catheter-related bloodstream infections. And so they were 2.2 times more likely with an ultrasound compared to their landmark procedure, which involved no ultrasound at all. So again, that comparison to patients who had undergone a procedure involving ultrasound and those who had not. So recognizing where, this is a surface probe, is it low risk? No, it's in fact, it's high risk. It's a semi-invasive procedure because you are essentially accessing body sites and accessing, where there would be contamination with blood, essentially. So the authors of that particular study recommended that they should have sterile procedures. You should make sure you have a sterile field. You should have sterile gloves, a sterile needle, sterile cover. So thinking about what I showed earlier about every aspect of that procedure, are you thinking about how appropriate that is from an infection prevention point of view? So they recommended all of these sterile barrier precautions, but they also recommended that the sterile tip, so the needle tip, should not come in contact with the sterile sheath of the transducer. So that's actually really difficult to achieve, and it's quite common that that needle tip will actually pierce the sheath itself. So this is why, despite that you might use a sterile protection on your probe, you still need to make sure that that device has been disinfected, because if that sterile sheath has been broken in any way, you then have the probe coming in contact with the patient. So just before my discussion on this today, I was talking to a lady in the audience, and she's brought up this exact topic with me. Probe covers don't replace the need for high-level disinfection. Just covering the probe, as we saw, we can have damage to the cover. So we know that they can fail. So different types of covers are used, and we have different rates of failure in those. So if you're using a cover and it tears during that treatment of the patient, and you've not properly disinfected your probe, it's too late. Your patient has been exposed, and there's nothing you can do in that point that you've already exposed the patient to essentially a biological risk. So all of the European guidelines agree with this approach, and so more and more you're seeing in the guidelines, as I said, recommendations around automated procedures, but also recommendations about how you use probe covers. And you can't just think that by covering a device or covering a probe that you're going to use with the patient is going to reduce that risk. Looking in a surgical setting and where ultrasound is used in a surgical setting. So this French study demonstrated direct transmission from their probe to their patient. So in open liver surgery, where you have essentially, these were patients that were being treated for cancer, and so most of the eight infection patients that they had were undergoing cancer treatment. So this particular outbreak involved Serratia marcescens, and so that had become connected with the use of the probe with those patients. So again, another indication of where you can see this probe is coming into direct contact with the patient's actual organs. So what actually caused the outbreak? So when they looked at it closely, they realized, their traceability as well helped identify all of these patients, that they recognized that the multi-resistant bacteria was Serratia. They also recognized how many failures they identified. There was no final disinfection happening with that probe. So they were cleaning the probe. They thought they were doing the right thing by cleaning the probe, but actually they never considered any disinfection. And this was down to training of the staff. The protective cover they were using, they removed it because they wanted to get a better image quality. So this is where, again, a gap of understanding that if you're removing that layer of protection, you're actually putting your patient at risk. And so they also recognized that they had a damaged probe. So no doubt that damaged probe, where they could see the seal between the cable and the probe body, was their actual source and their reservoir of that pathogen. So they're infecting patients, immunocompromised cancer patients with a multi-drug resistant organism. So the challenge is in trying to treat that patient, and the outcomes of that patient are really, really difficult. Ultrasound gel. This is one of my favorite topics in this, because if you look at all of these particular publications, and endocavitary procedures and surface probe guided interventions, these publications date back to 1998. We've been talking about this topic since then, and we've been identifying, and actually you can see there's a lot of these outbreaks are associated with one particular type of bacteria, Burkholderia. And so they're recognizing that this consistently happens with a water-based gel that's used on patients. We're using non-sterile gel, multi-use bottles of gel. And so there's lots of outbreaks in the literature identified. Today, across Europe, I think it's only the UK and France that mandate sterile gel, and there's tons of evidence to demonstrate that actually sterile gel is definitely where you'd want to go. So multi-use ultrasound gel bottles should never be refilled, for example. So managing that ultrasound gel, but actually making sure it's sterile, would definitely address some of this. And then actually, as soon as you're looking at procedures and trying to see, you know, where you put those layers of protection in, as soon as you start to use a needle, so where the needle is used, you're starting to look at a semi-invasive procedure, but you know that blood contact can happen with that probe. And so this slide kind of brings it all together. On the left-hand side, you can see the different layers of infection prevention that you need. But actually on the right-hand side, you're looking at the worst-case scenario if you weren't to do those things. So no probe cover, for example, non-sterile gel, but also considering things like a puncture site is contaminated, so the skin might be contaminated. The biopsy needle then passes through and touches that non-sterile gel, and essentially you're traumatically then introducing contamination and infection into that organ. And the organisms that we've found when looking at these types of situations are things like ESBL, Klebsiella, so another multi-drug resistant organism, Pseudomonas aeruginosa, and Staphylococcus aureus. So if you check the probes used for these procedures, you can see as well at the bottom, a lot of the times we can see where they get scratches. So I talked about needle tip touching the probe, so you can get needle punctures, and there you have probe damage happening, and probe damage where you get reservoirs of pathogens if they're consistently used. So obviously a damaged probe should never be used, but it's easy to see how that can happen. So in conclusion, looking at why we decontaminate ultrasound probes, we know we definitely need to protect our patients, but we also have to protect our staff performing the scans and what they're exposed to. Protecting and managing your facility risk, you can definitely see how if you have appropriate decontamination procedures, you can both protect your patient and your staff, but your reputation of your facility, so financially, but also reputationally. But I think, pulling all that together, it's really recognizing that there's risk to patients if these probes are not decontaminated. The risk is invisible. So we have a job to be able to educate our healthcare workers on how they're using the probes, how they're decontaminating probes, to understand that actually what you can't see is the risk to that patient. But we do know the risk is there. We know the evidence is there. The evidence has informed guidelines, and following those guidelines is something that you can easily adopt into your facility. So in the last section of my presentation, I want to talk you through some technology that addresses high-level disinfection and how you can do that consistently across every probe that you process within your facility. The Trophon technology enables to deliver protection for patients, staff, and the environment, but because it has greater reliability in terms of its reproducibility, most global guidelines are now recognizing automated methods. And this is a method that will be able to deliver that for you every time. So essentially, it's high-level disinfection of an ultrasound probe for every cycle, automated, and it provides high-level disinfection through hydrogen peroxide. Hydrogen peroxide, as we know, is a high-level disinfection that kills bacteria, fungi, viruses, and mycobacteria. So looking at all those risks we identified earlier in the presentation, using high-level disinfection like this will address all of those risks. And so at the end of each process, you will have also then only water and oxygen as environmentally friendly byproducts. So it's a very safe system, has no chemical exposure to the user, and the byproducts at the end are environmentally friendly too. And what's one of the most important considerations you have to undertake when you talk about what you're going to use on your probe in terms of disinfection is the ultrasound manufacturer and whether that compatibility with that chemistry or that technology is there. So every probe that exists will have instructions for use, and in that instructions for use, you should look there to see if there's an appropriate way to decontaminate that probe. And the Nanosonics Trophon technology has tested over 1,200 probes from 26 manufacturers. So this goes through thousands and thousands of cycles of the probe being loaded, disinfected, unloaded. And all that testing is done, but essentially it's the manufacturer who provides the approval. So the manufacturer tests those probes after they've been exposed to those thousands of cycles, and they give the approval. So your first port of call is always your manufacturer of your probe and looking at the IFU to make sure that that's compatible. The other highly important criteria, in my perspective as a microbiologist, is efficacy. So looking at making sure that there's high-level disinfection that's been tested and it meets all of the requirements, both for CE marking for Europe, but we have FDA clearance for the US as well. So this will cover all of the standards that you'll be familiar with for efficacy of testing across different ranges of different microbes, but also looking at specifically infectious microbes, so those that cause STIs, but also things like, we mentioned HPV, Clostridium difficile as the most difficult bacterial spore, and also drug-resistant bacteria. So all of the different range and the broader scope of efficacy that you need. So that's what we mean by high-level disinfection, if you can meet the efficacy requirements across all of those organisms. So the idea then that you can deliver high-level disinfection in an automated system but at the point of care is something that is really valuable to different departments that use ultrasound. So you can use as an integrated point of care device, and you can place it in examination rooms with no special ventilation, for example. There's no exposure to risk of hazardous chemicals because it's all self-contained within the system. The only PPE you would need would be gloves. So essentially you're using gloves when you're pre-cleaning that probe, when you're handling a dirty probe, you pre-clean your probe and you load it into the machine. So there's minimal hands-on time required as an automated system, so that time is given back to you to finish with one patient, for example, or get ready for the next patient. So being able to look at how workflow efficiencies work when you have an automated system, it allows you to have daily wake-up times, so it's ready for the start of your clinic, for example. It's sleep timer for where you have, power-saving mode. So there's different ways that you can use a device like this to ensure that it fits in with your clinical list. You can have the purging now, so purging of your disinfectant when it's at the time that suits you, but also overall the usability and the interface that it uses on the machine as well. It's extremely user-friendly, but you can have lots of settings to ensure that it fits in with your workflow and you can set up your list for that day. In terms of compliance, all of the traceability are linked back to using an AccuTrace RFID technology. So that's involved with the user card, but also the probe tag that you would use to identify that probe and trace that probe as well. And so all of that means that you have audit-ready digital records of all your processes of those probes that you've done in that machine. And so it records the probe, the operator, and the consumables and all of the cycle data to show that that process has met all of the required standards. So this is in line with all of the standards that you have for the Department of Health and Social Care, but also the HDMs that we have in existence for decontamination. So really looking at how Trophon 2 is rapidly growing as the global standard of care in ultrasound reprocessing. Today, 80,000 patients are protected from the risk of cross-contamination through ultrasound probes. And that high-level disinfection that it provides and equates to around 20 million patients annually. So this is something that is rapidly expanding globally across the UK and Europe and the US. So we have a big install base of lots of different probes. As I said, 80,000 patients each day are protected by this technology. So in summary, Trophon delivers demonstrated compliance across several different aspects I've mentioned already in terms of workflow, how it integrates into that, but also customized configuration as to how you use the device in your workflow and your clinics. But in terms of then, I mentioned some of the most important considerations around the microbiocidal effects and efficacy, but also then the probe compatibility program. So thank you for your time. If you're interested to come and talk to myself or any of my colleagues on the stand in Nanosonics, you're more than welcome. We really appreciate your time today.